talk, I'm going to give you some of my personal experience with how I think technology has changed my life, particularly in the practice of medicine, especially in EMS. And I think that, to understand how important it's going to be going forth, and how combining what you have, the expertise here between tech and medicine, and how it can come together to actually enhance what we do and make lives better and hopefully save lives. So let's wait for that first slide to come up here. No big deal. As a background, I practice medicine today. I've been practicing for about 30 years. I'm an emergency physician. And a quarter of my time I spend with what I call out-of-hospital care. These are the folks that when you dial 911 come to your home or to your public location, wherever you may be, and they take care of you. So I help train them. I help keep them certified and keep them up to date. And my personal area of research and interest is actually in the area of resuscitation. The area that is most dramatic in life is to take someone who's dead and to bring them back to life. So that's my personal focus of research, but I also have interest in other what we call time-critical care, time-critical emergencies. The two big ones that I've spent a lot of time in my life is looking at things to do with oh, you lost it? It was already on the desktop.
It was on the desktop. I'm not sure what happened to it, sir.
Wow.
Sorry.
No problem. So technical problems at a tech conference. Okay. All right. So that's sort of my interest. But my first slide really is going to talk about the fact that knowledge is growing exponentially, and essentially it's going to continue to grow exponentially from what you heard this morning. We are not going to be able to stop this onslaught of what the computer world is doing. It's bringing information to us so fast that our challenge now is none of us as humans have the manpower, have the human processing power to be able to keep up with what's going on. Papers are published constantly on a daily basis, and none of us can really keep up with this. So there's only one way, and that's going to have to be that we have to harness what's in computers and technology to make our lives easier. And then the third thing I want to point out is that we're aging, and you're the younger generation, many of you in this room, but those of you who are my age and in the mid-50s have a harder time because, again, our processing power slows. You slow with age, no matter what you can say about it. I can tell you I've slowed. So in certain things I still can keep up, but in many things you slow. And if you slow with age, it means that you have to you're even slower at processing. So the computer technology that he talked about this morning on, using, for example, with Parkinson's disease, it's huge. To ask a Parkinson's patient who has a very hard time with mobility to go in and record things each time is very hard for them to do. But if you made it, driven by natural smart processes, it'll be much easier. So I think that all of this sort of comes at the right time, because I think our real goal is to make the technological solutions drive improvements in healthcare. And just an example, when I started practicing in 1984, there were only 3 calcium channel blockers. These are drugs we use largely to control hypertension or heart rates in people. Life was simple. I only had 3 drugs to remember. You could use one drug here, one drug there, and one drug there. Now there's at least 9, and there's probably a lot more that I don't have listed for you. And some of them are used for certain indications. Some are used as a drip center. How do you remember all of it? How do you put all this together in your brain, and how can you keep this going? You can't. It's exploding way too fast. And for someone who sees a patient to come in on 15 drugs, 20 drugs, I have no idea which drug, if I give them, now they have some new problem, if I give them this medicine, will it make something worse or better? These things are what bothers me a lot, and that's where I think using smart computer-driven technology tools will help you. So my first project really was trying to understand what are called shock advisory algorithms. So one of the things that happens in cardiac arrest is you suddenly collapse, your heart stops beating, basically goes into a rhythm called ventricular fibrillation where your heart doesn't pump anymore. And the solution to this is to defibrillate it to make it work. The challenge is that the big defibrillators of the old days were too big, and so it was very hard. But we microsized them. But to microsize the defibrillator, it had to come now with something that could actually help diagnose what was going on, whether it was a shock. The top one is a rhythm you might shock, but the bottom rhythm you wouldn't shock. And so my first foray into the whole process was to develop shock advisory algorithms. So these are basically in a modern AED today. This is someone you can pick up in a public place and apply it on someone. It talks to you. It tells you how to do things. And a key component is the shock advisory algorithm. Basically, this takes those two pads that are placed on the chest and collects electrical information. And that pad information is fed back into a computer algorithm in the machine that basically will tell you to deliver a shock or not. The machine charges for you automatically and does all that. These things are so smart, they even have their own battery check, and they'll tell you when the battery needs to be replaced, when the pads need to be replaced. A modern example of how a defibrillator would used to take maybe this much room is now shrunk to something like this and has made life much easier. And for me, this was sort of the first time I got involved with technology, trying to understand. And my job was to decide which rhythms I would shock or not as a clinician. And then the computer, that was fed into a computer algorithm and helped develop it. So, a small sense of how in this whole process, the first defibrillators were created in the 1960s. But by the 1990s, they became hand-sized. And someday they'll be probably small enough to basically the size of your cell phone. And you'll be able to do it for anybody at any place. And like everything else, it's not static. It's evolving constantly. We know that these things take time, so the latest thing has been to try to decrease the amount of time it takes to actually make the decision-making process to decide whether to shock someone or not, because we want to reduce that time. Now, the next big piece that I started working on was something called CPR feedback. So when we do have someone in cardiac arrest, we basically start to do chest compressions. We try to move blood flow, because until you can restart the heart and the person has no blood flow, the only way you can keep the brain and the heart alive is to push on their chest. The problem is you push on their chest, but you don't know how well you're pushing. And what we've learned is it's not just to push on someone's chest, but you've got to go at the right rate, you've got to go at the right depth, and you've got to do it the right way. And how do you get that information? So we, in the system I work with, use something called the Philips MRX, which basically has an accelerometer, which is basically a machine that is collecting data and giving them feedback. But that machine isn't always available in real life for example, the AED I just showed you. So when we do this, guess it's got animation working for you. So we're collecting these signals, and by putting a pad on the chest, we can collect all this data. And it's this huge amount of information that we can collect, and it tells you what's going on, and you can use it. And one of the signals you can look at is something called the impedance signal. Now, the impedance signal basically is when you put those two pads, it's actually sending signals between the two pads. And those two pads are telling you what's going on with the chest wall. And amazingly, if you get someone back while you're doing CPR, you're pushing on their chest, and they now develop a pulse, you can actually see a change in that impedance signal. And if you see that change, it can actually tell you that the person doesn't need to push on their chest anymore. Usually, if you've been pushing for a while, these individuals, unfortunately, are not that conscious, so you keep pushing. But maybe they don't need for you to push anymore, and that's what we've been looking at. So some of the work I've done is with a group out of Spain that's been actually taking some of this data from our monitors and actually helping us determine whether you can, using fancy, again, first mathematical algorithms that are then put into a computer database, can help you figure out. And an example here is that these are two patients, and you can see on the top, these are two basically rhythm strips. And you could argue that they could both be perfusing, but this one isn't, and this one is. And the way you can do is you can basically take your mathematical algorithm, and you can create essentially a look at the impedance waveform that tells you whether the person is perfusing or not. And this can then come back to you as a feedback that's built into your AED. It can tell you, yes, the person's perfusing, the person's not. So you can see that the harness of information is there, but we don't always use it to drive clinical care because I think we tend to sort of get overwhelmed with the information. But I think where the bridge comes between technology and medicine allows you to basically make better decisions. So my hope with this kind of work is that ultimately, when you're doing CPR on someone and the machine's talking to you, at the same time, it's also measuring the impedance changes in the signal. It can tell you, hey, maybe you should stop here and see if the person has a pulse back. Because right now, there's nothing like that that exists. And you wait for the person to wake up often before you stop pushing on their chest. And that hopefully will lead to better care. So the next piece I got involved with was basically 12-lead ECG. So one of the most common causes of mortality in the United States is basically cardiovascular disease, and amongst those, something called an acute myocardial infarction. Basically, the plumbing to your heart basically gets blocked, and when that gets blocked, you basically, a part of your heart starts to die. And if you kill enough of your heart, you can die suddenly with sudden death, which is what cardiac arrest is, or you can basically lose a large amount of your heart and be functionally impaired because you won't be able to do much because the heart can't pump blood. When the heart can't pump blood, your body just can't function very well. So our goal in these individuals is to actually open up the artery as fast as we can and restore the blood flow. And the quicker you do it, the better the outcomes. And one of the tools we use is a 12-lead ECG machine. So we basically attach these leads. And right now, we're still limited. We actually use 12 leads, but there's technology out there that uses 40 leads, 50 leads, and gives you much more information about each part of the heart. But we use 12 because that's been the traditional approach that we've used, but that doesn't mean that we can continue to use 12. We could definitely use more. But when I first started working with this device in particular, I was struck by how poor the computer decision-making was. So this is an individual who's got an inferior myocardial infarction, which means the lower part of the heart basically is being damaged. And they have this classic ST elevation. Those of your medics in the room know this quite well. And they have so-called reciprocal changes. But the machine wasn't being very helpful. I mean, basically it's saying probable early acute injury. And, if you're someone reading this, you're like, what does that mean? Should I make a call? Should I trigger a response? Should I get people moving? I mean, most of us would look at this and say, wow, that's pretty dramatic. We better get going pretty fast and better get things moving quickly. So I spent a lot of time working with these guys, and this was their 2006 algorithm. And by 2015, the Philips folks have upgraded their algorithms again. So now you can see that not only do you have the same changes, but you have much more information. First, it gives you a trigger that there's actually an acute heart attack happening. Secondly, it actually even tells you what artery is involved. In this case, it's the right coronary artery. Our hearts are fed by 3 arteries, the right coronary, the left coronary, the left main, and it breaks up into the left circumflex and the left anterior descending. These 3 arteries basically supply a heart. You knock one of them off, or you knock all 3 of them off, or at least 2 out of 3 off, you can get a potentially major heart attack. So the idea is it tells you what's involved, and it tells you that it might even involve a particular side of the heart, which is the right ventricle instead of the left ventricle. All of this is information that's important because if you understand this, there are certain things you might want to do. For example, you may not want to give this individual a nitroglycerin when they're having a heart attack because that might drop their pressure more and they might end up having a worse heart attack. You might want to be prepared for the fact that when it's the right side, that's where the conduction system comes in. That's where your pulse beats are generated. So you want to be prepared for the fact that this person might stop beating normally and might really slow down. So you want to be prepared to pace this individual. So these are things that, again, shows you how the link between technology. You can't remember all of this. Some of us can, but those who can't, the machine can help you and think for you and help drive some of your thinking and some of your decision-making on scene. Another area that has been really rampant, that is, you've seen a lot of work in medicine, is clinical decision rules. And some of these are becoming more and more savvy. You can now pull them down on your cell phones. When it comes to the emergency department, we use a lot of clinical decision rules. And these have been developed and validated. We use something like the heart score to decide whether you should come into the hospital or not. If you're having chest pain, to be worked up for possible underlying cardiovascular disease. We use rules like the auto ankle rules, the nexus rules, the Canadian C-spine rules to decide whether we should x-ray a part of your body or not. The PERC score is a score that basically tells you whether you should be using something for whether you do a workup for something called pulmonary embolism. In EMS, traditionally, however, we've largely spent time deciding on triage scores, where you should go, which hospital you should go to. And one of the biggest discussions we're having right now is something called stroke score. So we know that stroke's a big deal in the community again, but the question really has been, can we separate strokes into what are ones that need more advanced care, what we call large vessel occlusions. And so most recently, in our system, in our community, we're having a discussion about taking certain types of strokes only to certain hospitals, again, using these sort of clinical triage rules. Now, the most interesting thing I've ever seen is something called Gideon, and I hopefully you can. Do you have that video link ready to go? Okay. And this is actually a very smart software. So one of my other interests, I grew up in Africa as a boy, and I was always interested and fascinated by tropical diseases. And Gideon is just fascinating because basically this man, Simon Berg, who created Gideon, essentially has put together a system in which you can figure out when you travel which country you've been to, based on your country, your symptoms, your physical findings, your lab tests. He puts the two all together and he generates a differential diagnosis for you. And to me, this is an example of, if you want to go to the, I think you had the link to the, looks like it fell off, right? So, yeah, you can play the video, yeah. You don't have sound though, right? So basically, it's going? You speak, it's okay. So basically what you do is when you go into Gideon, you sign up for this, you pay for it basically, it's a pay service, but you can get a 15-day trial for your own experiment. But I think this to me is probably one of the most, and this is where artificial intelligence really comes in, because essentially you type in where you travel. Let's say you went on a 3-week trip to 4 countries. You start the day you traveled, the day you came back. You put all the countries that you went to. You put down your symptoms, what you have. So you put down your age, and then you add some physical findings. You put some lab tests in. And from all of that, it puts it all together. Takes what's known about epidemiology, what's active and not active, and he's updating this thing constantly. And it generates for your differential diagnosis. And it'll point out to you what you have. And it's amazing that more of this isn't available today in medicine. And I think it's partly because I think we still just don't have the technical capability. But I can imagine this in EMS. So I can take a paramedic who's had 1 year of clinical experience. It's overwhelming. But if they were able to collect the key pieces of information they need and were able to input into a smart software, they could generate a bunch of differential diagnosis for them, particularly in patients in whom they have time to think through things. If you really have a time-critical thing where it's pretty obvious what you need to do, but as we talk about more what I call mobile community health, where we're integrating the hospital back and forth, this kind of stuff I think is going to be very important to help drive decisions, particularly on a 24/7 basis. We keep thinking they will have consultants helping everybody out, but in reality, manpower is expensive and nobody wants to be up at 1 o'clock in the morning waiting for a phone call. So I think computers, again, will make sense to me to change things in how we go. So got a minute left. I think that's probably my last slide. And I think I already talked about the wireless piece earlier, but I think that this is, again, where I see a lot of potential value, where we link a patient through their medical record back down to the field so they can actually understand what's going on. We're doing this now in our hospitals. We have something called the ED Information Exchange Network that Oregon has actually embraced. It was started in Washington. So when I see a patient today, I can see through Epic, which all of our systems use locally as their platform, EMR, I can see where they've been recently and what complaints they've been at. And it makes a huge difference in what I need to do about them. I can even know if they have a care plan, because then I can call the right people to help coordinate care. So I think you're going to see a huge merging of medicine and technology. Be prepared for it. I've given you a few examples of where I think it's shown a value, and I think you'll continue to see this expand. So I'll stop there. Thank you. Oh. Okay, sure. Jamie? Yeah.
So, aviation has had a similar transition to decision support tools and automation. And one of the terms they've had is skill attribute providers. How do you see that on the EMS side?
Yeah, so I think that, the way aviation has tackled it to some extent is through simulation, and I think that what you have to do is when you automate things, then the only way you can really test things out in real life is to put them into simulated environments. So I think simulation is really how you create scenarios and situations that are not necessarily going to follow the same pathway. And one of the things you also do is in your simulations you build in the failures. When the computer fails, when the machine fails, what would you do now? And it forces you to again react and how you'd adjust it. So I think what you have to do is you rely on technology, but technology will fail you, so you have to continue to have in your background the ability to react, and so that's where simulation can probably help. There's no doubt that clinical experience and expertise happens. It's not going to happen overnight. I think that for younger individuals who don't have a 30-year career like I have, I think these tools can help accelerate the pace of learning. But it will not replace clinical experience. Ultimately, technology will always need to go hand in hand with using your clinical experience. Plus, what the computer tells you may not always apply to a patient's values. So that's the other thing you have to consider. So you have to consider the fact that there is an individual who the computer may say X, Y, Z, but it may not necessarily, in terms of what the treatment recommended, but the patient may not value that. So it won't take care of everything. There'll still have to be a human-to-human touch. Other questions? Yeah.
So the other evening I was somewhat distractedly watching the national news, and there was a story that came on, and I can't speak to the veracity of this, but I believe they suggested that 30 million probably death error.
Yeah.
And with all of the technological advancements, some of which you've described, why is it still so high? What are the stumbling blocks that contribute to such a high number?
So it's these are great questions. And I think that a lot of medical decision error comes down to our cognitive biases. It's how we think. So if you've seen something, and it's also related to what I call the speed of medicine. So when we take shortcuts and we integrate our own biases, we begin to make bad decisions. So if you see an alcoholic comes into you, and if you're an EMS provider, you might have seen them 4 or 5 times, and they're drunk, okay? Now, if you're used to seeing that individual all the time, and they never have anything except they're drunk and they yell at you and they swear at you, you begin to put them into a category in your mind. No. Now, the one day they come to you, and they're actually acting drunk, but it's actually got nothing to do with alcohol. It's the fact they were hit on the head, and now they have what's called a subdural hematoma. And if you don't make the right decision, you end up taking this person to a detox facility where they die instead of taking them to the acute care facility. And that's where your biases come into play, how you've been trained to think. And what you've got to do is you must always stop and ask yourself, the computers can help, I think, generate that differential, but you still have to take care of your biases. And your biases will tend to mean you ignore data. So if you look at individuals who are sent home from hospitals or have wrong therapies given, people ignore pieces of information because they are biased in one direction. And there's a whole bunch of cognitive errors in medicine that we've identified. And I think one of the biggest things we need to do is to be aware of how we think when we integrate information. So computers will take information. We still have to apply it. The problem is how we apply it is affected by how we think. So you as a human being have a certain way of thinking. And you must ask yourself, how am I thinking about this? Am I being biased in a way? Am I treating this person a certain way because of my experience with them? Or am I really relying on the information? And I think the more objective you get, the less likely your biases. This is why science is so key. We were driven for years on expert opinion, and now we try to do randomized controlled trials. When you do a trial, what you do is you try very hard to take biases away. And when you eliminate bias, then you can have true evidence-based medicine. But the challenge is we are very much biased. And I grew up in Africa where as a kid, to me, I had a certain view of how the local population was. Now when I go back and teach them, and I'm teaching them as peers, I have to remove a lot of biases about myself because, when you come in a society where there were sort of three structures or strata, there was the colonials, there was the Asians, and there was the Africans. Now everybody's the same. These biases you got to take out of your brain. So our biases hurt us in decision making there. That's why we make bad decisions. So you got to look at yourself and how you think. All right. Thank you very much.